Good afternoon to everyone. Welcome to another online session of Jaipur Surgical School. So, just to give a brief introduction about this Jaipur Surgical School, this is an online initiative started under the guidance of Professor Kapoor for basically general surgical trainees living in low to middle income countries such as Nepal, Bangladesh, Middle East, and Africa. So, in this series, some eminent faculty from all over India or abroad gives a small lecture, especially in the topics which are pertinent to general surgical trainees. We are conducting this class every Friday from 3 to 4 p.m. Suggestions are always welcome to improve this online initiative. For the today's class, I would like to ask Kapoor sir to introduce the speaker.
Thank you, Piyush. So today we have a very special class in Jaipur Surgical School, which is a non-surgical topic, but it is a very important topic. And in the next few weeks, we are going to cover few other similar topics, which all of us, the surgeons, should at least have the basic knowledge about. We should know the principles. So today we are going to cover chemotherapy because we all deal with cancers, and either before or after surgical treatment, most of these patients, because they are in advanced stages, require adjuvant treatment either with chemotherapy or with radiotherapy or both. And of course, there are some cancers which can primarily, definitively be treated by these non surgical modalities. So it's very important for us, the surgeons, to know at least the basic principles, if not all the details of chemotherapy. And that is why I requested my colleague, Dr. Lalit Mohan Sharma, who is a senior medical and pediatric medical oncologist, to tell us about the principles of chemotherapy. So over to Dr. Sharma.
Thank you so much, Professor Kapoor, sir, and thank you, Dr. Piyush, for coordinating this activity. On behalf of the Mahatma Gandhi University and the JSS, I welcome you all on this uh, webinar or teaching session online. So, Kavita ji, can I have my first slide here? Oh, share करना पड़ेगा आपको screen. So, Dr. Piyush, is the screen visible to you and am I audible?
Yes, sir. Your audible and screen is visible, sir. You can make it full screen.
So, hope it is working now.
Yes, sir.
So, thank you so much. And today, in this JSS Jaipur Surgical School, we are discussing about the chemotherapy, primarily focused on basics of chemotherapy. It will not be very hi-fi things, and it will be very, very easy for all of us to understand. So once again, on behalf of Mahatma Gandhi University, I extend my warm welcome to all the audience. Very good morning, good afternoon, and good evening to all of you. So we'll be discussing about the principles of chemotherapy. We will not be going into details of the very fine details about the chemotherapy part. So we all know that the love and war both has taught us many things in life. And when it comes to chemotherapy, we will be talking and learning something from war first, then the love in the life. So what happened during the World War II? We can see on December 2, 1943, a Barij harbor was bombed by a flight, and out of these ships which were like attacked by the flight, they were carrying liquid mustard gas, and this mustard gas was a secret in a cargo where 100 tons of liquid mustard gas was there, and many ships were surrounding this, and it was observed that the mustard gas leaked because of the bombarding on these ships, and then it was found that those who got exposed, they had severe reaction on the skin in the form of blisters. Their blood counts were low and profound lymphocytes were depleted, and the whole WBC count was low in them. So based on that, many of them died, and the autopsies they suggested there was a depletion of WBC and with selective depletion of the lymphocytes. And then it was felt that the mustard gas leads to depletion of the white cell count and decrease in the lymphoid cells. And then after many years, the Yale Medical School they reasoned that this agent could be used to treat lymphoma, and this is how the initial nitrogen mustard, which was used in the bombardment, was felt that it could be used in certain cancers. So, chemotherapy, the basic meaning is to treatment of disease by chemicals. And for us, the doctors and medical professionals, chemotherapy means any drug used for treating any disease. In general, chemotherapy is being used as cytotoxic therapy, especially to treat and kill the cancer cells. So that was few aspects. So the first drug used for cancer chemotherapy was not originally intended for that purpose, and this was again the nitrogen mustard gas, and it was realized that the nitrogen mustard gas has been used in World War I, World War II, and during the military operations, the mustard gas was used to kill the enemies, and they were dying as a result of low blood cells. And then it was felt that if something is lowering the blood cells, is it worthwhile to try that in patients who are having high WBC counts or lymphomas or chronic leukemias? So, with this thought, it was realized that if you use the same irritating gas by the nasal route or you breathe them the nitrogen mustard, most of them they were depleted from the WBC and lymphocyte, but most of them had not recovery, and most of them they were dying. Another important, so it was realized that if you give intravenous, then probably the side effects are less, and gradually it got modified for a usage as we are using currently the nitrogen mustard compound. In 1946, Sydney Farber scientists they observed that in the leukemic cell lines when they used the folic acid, the growth of the leukemic cell line increased, and that's why they developed the folic acid antagonist, and we are using these days. So, in fact, this all is about the brief part history that initially some drug or something was there as side effect, and then it was taken into mainstream. So now the question comes that what is the difference between the chemotherapy and other treatment? So chemotherapy most commonly is systemic treatment, and the medicine they travel to the target organs, like for the breast cancer, if we are giving something intravenous or oral, it transport through the blood to all the organs, and major part reaches to the malignant cells in the primary and or if metastatic cells are there. So the route is again the intravenous route for most common drugs, and because of the toxicity on the dividing cells, like we want to kill the cancer cells which are rapidly dividing. So there are certain cells in the body which are rapidly dividing, like our hair cells, our taste buds, our GIT cells, our nails. They are also rapidly dividing. So the chemotherapy kills all the dividing cells irrespective of the site or whether they are diseased or not. So the person develops systemic side effect in the form of various like hair loss, nail bed changes, taste changes, sometimes diarrhea, vomiting, all those things are there. So currently we have more than 100 drugs as chemotherapy. Whenever we try to develop any new medicine in oncology or in other fields, also we should know that the initial research is in the laboratories, and then the research is in the animals, and further it is being researched in clinical trials on human beings. Why the chemotherapy drugs are so expensive when they are coming as first or from the innovator molecule? If you see the basic research, thousands of molecules and compounds are being studied at basic research. Out of them, few of these are being confirmed as drugs. And then we see that the preclinical research, 1 or 2% of these are reaching in the preclinical research, and then again very few are reaching in the clinical research, and only one out of the 10 or 20,000 molecules, one is approved. So the companies, the international companies which are the manufacturer of the drugs, they are charging the whole amount of the research from the drug which is approved in the market, and hence the drugs are initially too expensive. Later on, after some times, when the drug patent is over, then the biosimilars or the copied drugs are available in the developing world, and then the copied drug manufactured by many low and middle income countries, including India and other countries, the drug cost comes down to less than 10% or so in majority of the cases. Coming back to our main topic, when we talk of chemotherapy, before talking of the chemotherapy which kills the cancer cells, we need to know the basic structure of the cell. So, if we don't see anything other than one is the cell membrane, other part is the nucleus, and the third, the green part is the cytoplasm of the cell. And in the cytoplasm, various things are there which leads to nutrition, energy sources, and other things in the cytoplasm, and the nucleus has got nucleolus also inside. So mainly to remember, three things are there, and the cancer cells when they divide, they need to divide and like produce a copy of the similar material of genetic material into the daughter cells. So they need to divide from 1 to 2, 2 to 4, and then 4 to 16, like that, and they need to produce the similar genetic material to produce a cancer cell or a tumorous cells. So if we see the cell cycle, which is very important because many drugs are being used in the cell cycle specific phases. So if we see the G1 is the first phase of cell cycle. So this is first gap. And if we see it is the cell growth and accumulation of essential proteins as DNA binding blocks in this cycle of the cell growth. So this is lasting for 6 to 12 hours, and this is G1 phase, and the next comes as S phase. S stands for synthesis. So synthesis of DNA happens in the next. So in the first thing, the cell is accumulating the essential proteins to build up the DNA blocks, and in the second, the DNA is synthesized and the cell starts replicating chromosomal DNA material, and this replication phase lasts usually for 6 to 8 hours, and then the cell starts having growth. So then comes the G2 phase. So G1 S phase and then G2 phase. In this G2 phase or second gap phase, the cell is prepared for finally for mitosis. So mitosis is division of the cell, and they produce the equal amount of genetic material into the progeny or in the daughter cells. So the cell provides energy and synthesize the essential proteins here. And in the mitosis phase, ultimately the cell nucleus divides into two along with the paired chromatid. It separates from each other, and ultimately the this happens in the M phase. So the cell is ultimately producing two daughter cells which has got equal genetic material as the mother cell. This is happening in the human body, that we all are having 23 pairs of chromosomes, and the half is from the mother, half is from the father. So how does the chemotherapy works? So the chemotherapy works in different phases of cell cycles, and the important point here, one portion before the mitosis and G1 phase is the G0 phase. So G0 phase is the resting phase, and we know in the resting phase the cells sometimes go into this phase, and in this phase may last for many months or sometimes many years also. And our modern technologies, including PET CT scan, circulating tumor DNA, they cannot pick up cells when they are in the G0 phase. And that leads to ultimately relapses, which may happen many years after completion of the treatment. So this is very important. G0 phase. The zero phase cells, they have not yet started dividing, and they spend much of their life like hibernation. So it may last for many years, and this like is the ready to divide when they enter the M phase. In the S page, as discussed, that the chromosome containing the genetic code DNA, they are copied, and both of these new cells, they have the right amount of DNA, and then they go into the G2 phase, and then they ultimately go into the mitosis phase. So this is the cell cycle, which is important. Why this is important? Because there are various drugs acting in different phase of the cell cycle. So if we see like the G2 phase, the two drugs are acting. This is just for an example. So different cancer directed treatment, systemic therapy drugs, they are cell cycle specific. And for residents also, this is important for them to know, because cell cycle questions may be asked to all the residents, whether they are in medical, surgical, radiation, or whichever branch they are. But this is important for all of us to know about the cell cycle. When we talk of the chemotherapy, various drugs are being used. Who can identify this beautiful lady? Sonali Bendre, you all know. Anybody from outside India can identify this lady? She is a film star, Sonali Bendre, and she is like one of the most preferred actress by the youth at that time. So when we use chemotherapy, the deciding factor that which drug is to be used is dependent on the tumor biology. It depends on the cellular kinetics. It means how rapidly the cells are dividing. Depends on pharmacology, that one particular tumor is sensitive to one particular type of drugs, and then comes drug resistance, and the last depends on the host factors also. Somebody may tolerate some drug, somebody may not tolerate that drug. So this is about the basic or molecular basis of cancer. If we see, it is the early tumor, so the initiation, promotion, angiogenesis. So angiogenesis is very, very important. Angiogenesis is taking blood supply and formation of new blood vessel. So the tumor cells, they secrete certain cytokines which attracts the blood supply from the nearby blood vessels, and this formation is known as neoangiogenesis, which is characteristic feature of cancer. So after this, there happens invasion. So invasion is they lead to breach of the basement membrane and they get into the circulation. And once the tumor cells they get into the circulation through blood, they reaches to different distant sites, including the liver, lung, brain, bone, and depending on different sites, it goes and develops as metastasis. So whenever we see a metastatic disease, we need to know that this cancer has already spread its beyond its normal boundaries, and metastatic disease in the lymph node also happens. So this pathway is there, and there is rapidly increasing genetic changes at each step. So the currently available modalities, we can pick up the changes during these phases. Also, certain molecular markers are there, but for the clinical part, we see only when the tumor is enlarged or when the tumor is in the lymph node, like examples in breast cancer, in head neck cancers, or many times when the tumor has led to metastasis, we are able to pick up these cells. This is about the growth of cancer cell, that each cancer has a different type of growth in the cells, and sometimes even in the same tumor, the cancer cells might have different growth. So most commonly it is sigmoid growth, and sometimes it is the linear growth, and in some cells it is the exponential growth. So can anyone of you tell me that which cancer has got highest proliferation of the cells? Burkitt's lymphoma. Say loudly, Burkitt's lymphoma. So you can come for, on the forward seat. Burkitt's lymphoma. Yeah, please come forward. Burkitt's lymphoma has got very rapid turnover, and the cells are very rapidly growing. So in that we need to give certain chemotherapy drugs which acts faster in fact. So we don't want slow acting drug. And a disease like prostate cancer, the cancer cells are too slow growing that many times for we don't need treatment also for many of these cancers. Sometimes you say low grade lymphoma, chronic lymphocytic leukemia where patient does not have any symptoms. So the growth is very, very slow. This is the combination that what happens if you do not give any cancer directed therapy, the cancer cells keep rapidly increasing and which may be lethal also. If you are using one drug, then the cancer, the cells, the number of cells, they are decreased. So you can see here with one drug, the cancer cells are decreasing by one log kill. But within 3 weeks or so, it is increasing by it is killed by three log kill, and in the gap it increases by one log kill. So this happens, and with each cycle there is some certain amount of cancer cells getting killed. If you use two drugs, so these are different mechanism of action, drugs are available which kills the cells from two different mechanisms. So in that, the individual drug toxicity is less and the efficacy is much more. So two drugs with different mechanism of action which may be synergistic, so the cell kill is higher as compared to only one drug here. So toxicity is less, and that is the rationale that for many cancers we are using doublet chemotherapy, may it be breast cancer, may it be ovarian cancer. it is being used as doublet chemotherapy. And here we can see that if you use more than two drugs, then the cell kill is further higher. Like in the that remains rationale of like treatment of acute lymphoblastic leukemia. We use many drugs in combination in a cyclic fashion. अभी तो ये चाय तो सबके लिए मंगवा देना मुझे. Thank you so much. So this we can see here that this happens when you use multiple drugs. So this is the sigmoid curve, and if you use effective drug, you can decrease the growth and you can bring down. So can anybody tell me that which cancers are curable with chemotherapy alone? Priyanka, which cancer is curable by chemotherapy alone? So the blood malignancies. So one is hematolymphoid malignancies. Any other solid tumor? Anything related to females, related to pregnancy? The gestational trophoblast. Yes, so they are also very highly sensitive, and the testicular tumors are also highly sensitive, but they need surgical intervention for the primary at least. So we need to know that part. So this is what happens that during the, if you see the growth of cells, so our current modalities, they are able to see the diagnostic threshold of 1 centimeter tumor, especially in solid tumor, the cell load is 10 to the power 9. So the cells keep growing in the body. Our modern methods are not able to identify this much number of cells. So by the time a tumor is formed, there is 10 to the power 9 cancer cells load in the body, and then this starts growing, and this becomes a fatal here at 10 to the power 12. So this is the detection threshold, and this is threshold if you don't treat them. And so undetectable cancer is here, and this is very, very important that with available modern methods, probably we may be able to see the cancer and diagnose them at early stage, which currently outside the clinical research laboratories, we are not able to see them. So this is the normal cells, and ultimately this leads to like the doubling time is important for cancer cells, and rapidly proliferating cells have rapid doubling time, and many times within few hours the cancer spread. Like take example of lymphoblastic lymphoma, it doubles very rapidly and leads to serious complications immediately. So we need to act very fast. Sometimes the tumor growth is slow, and this happens like this is the inherited risk, and gradually after the insult from the carcinogen, which may be a viral etiology or maybe something else, the cells they develop dysplastic changes. If not taken care here, ultimately it leads to dysplastic, then it leads to carcinoma in situ, and after many years it developed a full blown carcinoma. So can anybody tell me that which cancer behaves like this? That after the introduction of the carcinogen, it takes many years, maybe 10 years, 15 years to develop a full-blown cancer. HCC is one. Yes. So HPV related cancers are very common. So CA cervix. So when the after the introduction of the HPV through the sexual activity, it gives us many years. Of course, in more than 90%, it is cleared by our own immune cells or immune system, but rarely it can lead to dysplastic carcinoma in situ and ultimately invasive carcinoma. So the invasive carcinoma is the stage where it becomes detrimental to the health. Even if it is in situ, we can cure with that. So the carcinoma cervix is the model which again gives us more than 10 years for us to act. Dr. Priyanka, which method leads to detection of the precancerous changes in carcinoma cervix? How can you pick up early changes before development of cancer? Pap smear. So with the pap smear, we can see early changes, and if anything wrong is happening in the cervix, through visualization of that, we can cure that by conization or by thermal or by cold ischemic ablation of that can be done. So we have three types of cells in the malignancies: actively dividing, resting cells like in the G0, which has got potential to multiply, but they are not currently multiplying. And we are seeing the other cells which has got non-dividing without potential to multiply. Actively dividing cells in a tumor is less common. It is a small fraction, and most drugs they are working on the actively dividing cells. So if you see a 10 centimeter tumor on imaging, if the 30% cells are the small fraction of actively dividing, and when you give chemotherapy, there is rapid reduction. So we say from 10 centimeter it's come down to 3 centimeter or 5 centimeter. So there is a rapid decrease in the fraction of the dividing cells. Same drug kills the normal dividing cells, and this leads to side effect as discussed in the previous slides. So the tumor kinetics again depends on the reflection of proportion of growth of the tumor cell. Some tumor cells are very rapidly dividing, like discussed lymphoblastic lymphoma. Some tumor cells are very slowly dividing, like chronic lymphocytic leukemia, low-grade lymphoma, testing the prostate cancer. The doubling time is very important, and many things are based on the doubling time, like selection of chemotherapy, the frequency of chemotherapy. It is dependent on the doubling time of the cancer cells. So tumors grow most rapidly in small volume tumor, and the tumor slows as the growth becomes less as the tumor grows, and we have seen the growth curves also. So this is very important for us to understand that when you give chemotherapy, what happens? Like this is the threshold where the tumor cells are, the where the cancer is picked up 10 to the power 9 cells. You give chemotherapy first cycle here, maybe combination or maybe single or maybe triplet. You started here, and then within 2 to 3 weeks, there is three cell log kill. So three log cell kill. So from 10 to the power 10, you have come down to 10 to the power 7. But within the break, one log is increased. So again, this becomes 10 to the power 8 here. And then here you give the second cycle after 3 weeks or 2 weeks. So once you give the second cycle, again three log kill. So from 10 to the power 7 or 8, it comes to 10 to the power 5. But in the gap, again it increases by one log. So it becomes again one log higher. And here you again attack, and then there is like three log kill. So by giving 6 cycles, you bring down the tumor load to lowest possible level, and then most commonly we wait and watch, and our methods cannot detect anything below this 10 to the power 9. So we are giving 6 cycles, and then we are keeping the patient on observation. Many times the body's immune system, it works, it does not allow the cancer cells to grow further, but many times the relapses do happen and the cancer cells grow again. And this remains a rationale that if you treat a case of multiple myeloma, if it is transplant eligible, we give chemotherapy and we bring down the tumor load to lowest possible level. At this point, again, you do autologous stem cell transplant. So here you bring down the tumor load to further down and lowest possible level so that the relapse does not happen early. So this remains the rationale of using 6 cycles of chemotherapy most commonly, and I'll be covering the dose dense chemo also in next few things. So this is 1 centimeter mass, and we can see that this is like non-curative therapy, and this happens many times. The patient do default after 1 or 2 cycles or 3 cycles. Your PET CT scan is suggestive of very good response, and the patient defaults, and again the disease recurs here. In the ALL, especially if you see the within 4 weeks of induction chemotherapy, the bone marrow suggests it is clear of the disease, but still you are giving chemotherapy for 2 years. So the rationale is that this much amount of the disease burden is there inside the body. So we want to get rid of this all lowest possible level, and then once it comes down to certain lowest level, then our own immune mechanism, it kills the residual tumor cells. So this remains the rationale of prolonged treatment even after achieving the complete remission. What happens? What is the importance of having full dose of chemotherapy? So these are bit old slide, but if you give, like if you compromise on 50% of the dose, you compromise almost 20% of the outcome in the cancer. So we should not compromise on the doses in the chemotherapy part. This we have discussed. And this is important for us to see that Goldie Coldman hypothesis, that the cancer cells acquire spontaneous mutation, and this may be responsible for the drug resistance. And the modern methods, they suggest that we should do NGS on each disease progression, because we are able to pick up the the mechanism of resistance during the treatment. So sometimes the patient showed good response, and suddenly after many years the patient develops resistance and the disease progression happens. Combination chemotherapy, we have seen that with the combination chemotherapy, maximum cell kill is there, and the toxicity of individual drugs is less, and we are able to give the broader range of coverage of resistant cells also. And this is how it happens. And the combination chemotherapy, it prevents or it slows down the development of resistance in new cell lines. So this, I think we have already discussed. Concept of log kill is already there. How do we give chemotherapy? These are the modes of administration. So most commonly we understand that intravenous is the most common route, but oral and sometimes other routes are also being used. Can anybody tell me about the intra-arterial chemotherapy? When do you use that? For taste, very right. So for hepatic tumor, when you want to deliver high dose at local site, then you use this. But this is applicable not in all. Like for the breast, you can't do like that. Then intrathecal chemotherapy. Can anybody tell me where do you use intrathecal chemo? For the blood-brain barrier to cross. So when you want to give, yes, so to prevent the disease spread in the brain, or when you want to treat the already diseased brain, like take example of the leptomeningeal metastasis, then we use the intrathecal chemotherapy. Intraperitoneal chemotherapy is being used for ovarian cancer, and my surgeon colleagues nowadays they use the HIPEC. So in that HIPEC also they are using chemotherapy drugs, which is like higher concentration in the peritoneum after complete resection, so that the cell kill is higher and it acts locally rather than the systemic action. We need to see the combination chemotherapy. We need to see on one side we are seeing the activity of the drug. We want to get rid of the maximum number of cell kill by the disease by the drug. Another part is that safety is also equally important. So the cancer chemotherapy is not like easy drugs that may lead to serious side effects, which can be fatal also sometimes. So this we have discussed that drugs with different mechanism of action can have additive or synergistic action. Drugs with different dose limiting toxicities are available, and we are using the drugs in certain optimal dose and schedule. So like ovarian protocol will be different, lung cancer protocol is different, acute leukemia protocols are different. Why do we give treatment free interval in cancer chemotherapy? Now, Priyanka, why do we give break? For the body to recover from the toxicities of the. So normally there is toxicity, systemic toxicity, which can be like especially the hematolymphoid cells also go down. So with each cycle of chemotherapy or WBC, myelosuppression is there. So we allow the body to recover from the side effect of chemotherapy. So drugs with different pattern of resistance, we combine them so that the side effects are less. The common side effects for which the patients are worried, that is alopecia, because especially for the females it becomes a issue of serious concern. But for us, for clinician, myelosuppression remains most important, and this remains our responsibility that we do not produce severe myelosuppression, because any patient who develops neutropenia because of the decrease in the WBC cells and because of reduced neutrophil count, the risk of infection is higher, and sometimes the infection may be fatal also in these patients. So one important point is about the myelosuppression, alopecia. Other is about the GI toxicity. So in the oral cavity, one can have stomatitis, ulcers, or painful lesions in the oral cavity. One can have nausea or vomiting or loss of appetite. or sometimes it may lead to diarrhea also, like certain drugs or certain groups are there which lead to diarrhea. Then comes the ototoxicity also is important. So ototoxicity can be, Priyanka, can you name one or two drugs? So platinum compounds are there, so that is most commonly used, and most commonly it leads to ototoxicity. So when we give cisplatin or platinum compounds, we do their hearing test before giving the drugs, because many times patient may not be aware of the hearing loss, and sometimes they are under too much of mental pressure that they will say that I am not worried about any side effect, you just treat the cancer. Nephrotoxicity and kidney dysfunction, liver dysfunction, neurotoxicity also is important, and many times these patients undergo radiation also, so the complications are much higher. Pulmonary toxicity is important, so can somebody name me one drug which leads, bleomycin leads to serious pulmonary toxic including fibrosis. Cardiotoxicity, which drugs lead to cardiac toxicity? Anthracyclines, and so one is anthracycline, other than that, so drugs used in breast cancer, trastuzumab, pertuzumab. Even radiotherapy also leads to cardiac toxicity or pulmonary toxicity. Gonadal toxicity is also important. At our center, we have got a facility where we do semen preservation or ovarian preservation or oocyte preservation. How do we treat? Bone marrow suppression remains most important point. So for the anemia, we give blood transfusion, or sometimes based on the disease part, we use with the erythropoietin or darbepoetin. For thrombocytopenia, we give platelet transfusion only if person has got serious bleeding tendency, or if the platelet count goes less than 10,000 in our institute, but for community setting, 20,000 is good enough. We give romiplastim and other drugs to increase the platelet count. Generally, if it is a metastatic setting, if patient is having non-curable disease, then we do not be too aggressive, and if the first cycle shows that patient has developed severe toxicity, we reduce the dose in the next cycle. Neutropenia remains big challenge, and neutropenic it should be anticipated, and the growth factors we use even before the drug is being given. So that is prophylactic growth factor. Even local reaction can be there. So these are the drugs which can lead to local reaction in the form of having bullous reaction, sometimes allergic reaction. Even if it is extravasated, it may lead to serious skin toxicity, and sometimes may need even plastic surgery also. So we need to be very careful when you are using cytotoxic chemotherapy through the peripheral route. We need to monitor immediate side effect, as well as we need to monitor for the toxic effect, which can be later on also, and we need to educate the patient and family also about the possible side effect. Next important point remains, various terms are being used for chemotherapy. So for the chemotherapy part, when we use induction chemotherapy, it is high dose chemotherapy, especially for acute leukemia setting, where with multiple drugs we want to achieve the cell kill, and we want to bring the patient into remission. Consolidation, we are using repetitive drugs of induction treatment after achieving complete remission. So where we want to achieve the long term cure or long term remission. So induction chemotherapy, and then comes the maintenance therapy. So maintenance therapy again to keep the residual load of the cells at lowest possible level, we use maintenance. So like acute lymphoblastic leukemia, we use the maintenance for 2 to 3 years. For AML previously we were using, but nowadays we are not using. For myeloma also we are using the maintenance therapy. Another important term which we all should know, neoadjuvant chemotherapy, when we are using chemotherapy before the definitive local therapy. Local therapy may be in the form of surgery or maybe in the form of radiation. This is being used mainly to reduce the tumor bulk. Adjuvant is anything after the local therapy. So maybe surgery or maybe radiation or maybe combination of both. So if anything is being used after the local therapy is adjuvant. Palliative word we use when we know that we cannot achieve cure. we can achieve only the control of symptoms or prolongation or achievement of good quality of life. So we call it palliative chemotherapy. Salvage chemotherapy, that after high dose chemotherapy, to kill the residual disease, we are using certain drugs. These are the response criteria when we are giving chemotherapy. We see either the disease has completely disappeared, that is complete response, partial is when there is 50% reduction, stable is between 25 to 50%, and we call it progressive disease when there is any new lesion or when it is like 20%, 25% increase in the already existing lesion. This is the graph that if you compromise on the doses, you compromise on the response. Like this is if you are given optimal doses, and this is when you compromise on the doses. So instantly, you and your patient will be happy that the side effects are less with the low chemotherapy doses. But if you see years after the chemotherapy is over, the chance of relapses are higher if you use the suboptimal doses. Alternating dose of chemotherapy, usually it is not effective. Dose dense therapy nowadays, like we are using for breast, we are using high dose therapy, and one is when it is palliative intent, we are using low dose therapy. So these are various combinations. These are various protocols that sometimes we use the drug once in 3 weeks, sometimes we use the drug weekly. So depending on the protocols, we use various drugs and we call this protocol. Like for Hodgkin's lymphoma, we call it ABVD chemotherapy every 2 weekly. So the aim of chemotherapy, as discussed, it could be either cure or control. It could be purely controlled by or cured by the chemotherapy. It could be the neoadjuvant, adjuvant concurrently when you are giving with radiotherapy, or it could be purely for the palliative intent. These goals we have discussed already, that palliative chemotherapy we use mainly for the symptom control, and in the palliative chemotherapy, since the patient does not, we don't expect the cure, so many times we use the oral chemotherapy also, we call it metronomic chemotherapy. Intravaginal chemotherapy is being used specially for the urinary bladder tumors, where we use mitomycin C in the bladder. The aim of giving chemotherapy is to kill the micrometastasis, because cancer is no longer a solid tumor residing only in the tumor site. In 1960s or so, we were doing only surgery and then the patient was getting relapse. But nowadays we know that when a tumor is being operated, micrometastasis already there. So we kill the micrometastasis by giving chemotherapy, and especially like we see Wilms tumor, osteosarcoma, or acute lymphoblastic leukemia. Most of these patients, they will be relapsing. So I think we have 15 minutes more. So coming towards modern, the conventional chemotherapy is like doing bombardment, that we are killing the cancer cells, we are killing the normal cells also along with the cancer cells. And the targeted therapies nowadays available, they are working like missiles. So they hit the target, they do not destroy the whole area in fact. So cytotoxic chemotherapy mechanism of action, we have understood. The targeted therapies nowadays with various genes can be mapped and we can know various mutations in the cancer pathways. So we know about the genes, we know about the pathways, we know about the pattern of metastasis also, and we can anticipate the resistance also. So various drugs are available, like monoclonal antibody is available, which targets against the particular antigen. So like CD20 positive lymphomas, we see, like we see the ERPR positive breast cancer, we see various monoclonal antibodies are available and various targetable drugs are available. Tyrosine kinase inhibitor, these wherever you see IB at the end, these are the tyrosine kinase inhibitors. So the selective action, we need to work very hard and we need to act early and we need to hit the target so that maximum cell kill is there and unnecessary side effects are not there. So this was a Time magazine which published like a magic bullet, and this was Glivec when imatinib was introduced by Novartis company. And before introduction of Glivec or imatinib, most of patients they were dying as a result of CML, and very few were going for the bone marrow transplant, which was again uncommon for developing world to have. So with the introduction of this tyrosine kinase inhibitor, the CML, now transplant has gone out of the CML therapy in majority of the cases, and most cases now we are able to see the cure also with them. So these are various other targeted targets available, and these are the drugs available, and these are the cancers where these are being used. So, like various targetable HER2 positive breast cancer was once considered a very poor prognostic disease, but now with the availability of anti-HER2 therapy, the breast cancer prognosis is improved and it is good prognosis. These are the tumor, like already discussed about the highly responsive to chemotherapy, and these can be cured with chemotherapy. So, other than hematolymphoid malignancy, choriocarcinoma, Wilms tumor, germ cell tumor, these are responsive to chemotherapy. These drugs, these tumors, they have good improved outcome as a result of chemotherapy along with the local therapy. So all these solid tumors, local therapy is a must. We cannot get rid of the cancer without local therapy when we are achieving or when we are trying to achieve a potentially cure in these patients. Palliation, we know that many tumors cannot be cured, so we achieve good palliation or good long term control of the disease with various chemotherapeutic options. Chemotherapy usually is not effective in malignant melanoma, renal cell carcinoma. Usually they are resistant. Metronomic chemotherapy, as discussed, that it can be either oral chemotherapy or it can be a intravenous plus oral, and this is low dose chemotherapy at repeated intervals. So this also is very effective in symptom controls. These are the conditions when chemotherapy may be withheld, especially the febrile neutropenia, thrombocytopenia, pregnancy, or when the patient is unfit to receive the chemotherapy. Chemotherapy is like doing a serious job, and when the patient is unfit based on the hematolymphoid parameters or based on the condition, we need to be careful. If you infuse chemotherapy during pregnancy, we may lead to fetal damage also. The side effects we have already discussed. Immunotherapy is new kid in the treatment of cancer, and we have seen that various chemotherapy checkpoint inhibitors are available, vaccines are available. So cancer vaccines are either preventive, like HPV vaccine is available worldwide, hepatitis B is available. So it can be either preventive or it can be sometimes even after cancer also. These vaccines are effective, not in cervix, but in few other cancers. So the future of oncology seems that it is evolving and understanding the molecular mechanisms and pathogenesis, especially genomics and studying of gene and genetic mutations. We are having a lot of molecular targets to available. Some of them are targetable mutations, some of them are non-targetable mutation. But we see that gradually the combination chemotherapy that is going away, we are having more of targeted therapies available. Characterization of the tumor molecular phenotype. This again is very, very important in the management of cancer. And this will require development of various targeted therapies where we can closely target various tumors in one go. Like take example of MSI, microsatellite instability. So the drugs immunotherapy is approved in all cancers. So maybe lung cancer, maybe melanoma, maybe kidney cancer. If you target that, it is effective. So in coming few years, we will be having more and more of the drugs which are like based on the molecular profiling. And with this, I end up and I thank you all for your patient hearing. And I invite any questions or comments. Thank you so much.
Yes. Any of you want to ask anything?
Any questions any of you want to ask or add to whatever this was very, very basic discussion?
So, Dr. Lalit, for the surgical audience, are there any solid tumors, especially in our domain, GI and HPV, where induction chemotherapy would be playing a role? Because you said it's mainly for hematological.
Yes, sir. So especially like we see carcinoma of stomach, esophagus, These are chemosensitive tumor, and many times the patient, the we are giving neoadjuvant chemotherapy to downstage the disease, and it gives a time also to understand the biology of the disease. So GI cancers, especially stomach, esophagus, or even gallbladder, also sometimes we see that almost one third of the patients, they may be showing good response to chemotherapy, and we may convert them from inoperable to operable. Pancreas, yet it is not very clearly, but colon again is very important in the GIT, where neoadjuvant chemotherapy plus radiation both are working in the rectum carcinomas. So this is like a area where we give chemotherapy, we see the sensitivity of the tumor cells also. If a tumor is showing response initially, it will show like good response later on also. So it gives us a window to understand the biology also. So these are the few tumors.
Yeah, I think this is a very important point, which all of you, the medical oncology students and surgeons, also have to understand that neoadjuvant treatment, whether it is chemo radio, or radiotherapy alone, in addition to making a large, locally advanced, unresectable tumor into a possibly resectable tumor, now many people use neoadjuvant therapy even in upfront resectable tumors. And how it helps? That while you are giving neoadjuvant treatment, if the patient shows progression, or more importantly, if the patient still throws metastasis, then you are dealing with a very aggressive biology tumor. In such a case, even if to begin with the tumor was resectable, even if we had done surgical resection, the outcome will be poor. So you are selecting cases. You are not operating upon those patients who have an aggressive biology tumor. You are operating only on good biology tumors. And that is why, as a group, your results will be better. So this is called selection of good risk cases for surgery and selection of aggressive biology cases for definitive or palliative chemo or chemoradiotherapy. Second is this term metronomic. Most of us, the surgeons, are not aware what exactly is metronomic. You did mention, but maybe you can repeat again. What do we mean
So
by?
metronomic is chemotherapy, certain drugs of like two or three drugs together we are giving, and we are giving in a very low dose chemotherapy, and this is being given in a fashion to control the disease. So many times, like solid tumor, take example of ovary, breast cancer, when we know we cannot achieve cure of the disease, we give the two or three drugs in a like very low dose, where toxicity is minimal, hospital visits are minimal, and the patient is having reasonable control of the disease. Even some disease like fibromatosis, fibrosarcoma, where we don't have effective treatment. So these can be controlled very well for the metronomic therapy, and it is always advantage. The cost is less, especially for the developing world. The cost of therapy is less, and we can achieve good control in metastatic setting.
But this will be only in palliative setting.
Yes, sir.
Now, HIPEC you mentioned. So there you said one advantage is that we are giving the drug locally into the peritoneal cavity. What does the high temperature do? Why hyperthermic? Does it increase the penetration of the drug into the tumor cells? Because we usually use the high temperature, I think about
Yes, sir.
42 or 40 plus.
I think I'm not well.
Piyush, you know what does the hyperthermic infusion do?
Basically, it is to increase the penetration, local penetration of the chemotherapeutic drugs. So these mitomycin C and other drugs usually works well when the temperature is increased
Okay,
locally.
okay, yeah. So both the factors, one that we are giving it locally, and second is the high temperature, which increases the perfusion or diffusion of the drug into the tumor cells. Uh, uh, Many a time we say that we are giving 5-FU not as a chemotherapeutic drug, but as a radiosensitizer when we are giving with radiotherapy. So can you just?
So, in fact, many drugs are being used as radiosensitizer. So, it means the aim is not to achieve the cell kill by the chemotherapy drug, but it leads to sensitization of the cells. So, when they are exposed to the radiation, the cell kill is much better. So that happens with the CA cervix, with head neck cancers, and few other cancers. So it becomes low dose chemotherapy at a like weekly interval, and it is not cytotoxic dose that if given alone it will not achieve a cell killer benefit.
A word about folinic acid. Very frequently with chemotherapy we give.
So in fact, especially with the methotrexate we use, where the free drug concentration is higher and many times it leads to toxic effect. So after like 42 hours or so, we are using the drug so that the toxicity remains less while maintaining the efficacy.
And S1, which is very favorite drug of Japanese oncologists.
So in fact, sir, we have also started like a few Indian companies have brought this molecule now. So this is very favorable. Like the toxicity is less while maintaining the efficacy. The oral capecitabine or 5-FU has got a lot of side effects. So this drug has been found to be less side effects and efficacious. And we also like experienced over more than a year or so now that the side effects are less while the efficacy is being maintained.
And it is a pro-drug of 5-FU.
Yes, sir.
Piyush, anything you want to ask or add?
Yes, sir. So first of all, thank you for this comprehensive lecture on chemotherapy. So, sir, as a surgeon, I would like to ask, like now in a lot of GI malignancies, we are using neoadjuvant chemotherapy. So, what should be the ideal timing for surgery after chemotherapy, especially when the patient has not received radiotherapy? And what should we look into and keep in mind before posting a patient for surgery when he has received the chemotherapy?
So I think from the chemotherapy part, the most important is when should we offer the surgery. So it depends on the different type of tumors. Like for the ovarian cancer, we see that if a patient is showing good response, we complete the chemotherapy because nowadays we realize a solid tumor is a systemic disease, it is not a local disease. So more and more achievement of micrometastasis killing is achieved, the better will be outcome. So for the solid tumors like ovarian cancer, 6 cycles, breast cancer, in certain subset, we want to achieve the maximum cell kill. So our target remains the pathological complete response before the surgery. So when after you operate upon and there is complete pathological response, we feel that chemotherapy has worked well. For other cancers like the G junction or the stomach cancer, the colonic cancer, usually 2 to 3 months is good enough. So usually like 3 cycles, 4 cycles, float chemotherapy 2 months. After the CT plus RT, usually 4 weeks time is good enough. If somebody has received chemotherapy, then the maximum benefit before surgery is usually like after 3 or 4 cycles, and there is no point in continuing because there may be certain subset of cells which might not be sensitive to the chemotherapy. So if beyond 3 or 4 cycles, when we have achieved good cell kill and we continue giving chemotherapy, we may not be achieving benefit and the resistant cells might be proliferating in the tumor. So if those cells can be removed by the surgical intervention, then probably we'll be knowing that how much chemotherapy has worked, and there is a chance that we may change the chemotherapy protocol in patients who do not show good pathological response.
Rajen, you want to add anything? Dr. Desai?
No, sir, nothing particular.
Okay, thank you. So, Piyush, when we can close?
Yes, sir.
I would like to thank Dr. Lalit, my colleague in medical oncology here at the Mahatma Gandhi Hospital. And as I said that as surgeons, we all need to know about all these ancillary modes of treatment. And in the same series, we are going to cover radiotherapy also in one of the future sessions. I think Dr. Piyush will post the schedule. He's already posted the schedule. What is the next class, Piyush?
Sir, it will be on gadgets in surgery.
Okay, Dr. Kamaljeet.
Yes, sir.
Yeah, so next is a very important class again for surgeons because Dr. Kamaljeet Singh, who is again my former fellow from SGPGI, he will be talking about various gadgets which we use during surgery and which every surgeon should at least know the basic principles so that we can use it properly, adequately, and avoid any problems or any complications related to misuse of gadgets. So that will be on 12th. Okay, Piyush, I think we can close. And thanks to the Dwarika team for technical support. Thank you.
Thank you so much. Thank you, everyone.
Thank you.